This is Case Study X, Release of Information in the Electronic World for Applied Health Informatics in 2017. Members of our team are Jean Reeser, Director of Health Information Services, Christy Merritt, Director of Legal Compliance Office, Alexandria Simmons, EHR Technical Manager for Medical Records, Jimmy Roberts is our Director of Informatics, Brittany Rivers is our Patient Family Representative, I am Jake Johnson, Chief Information Security Officer, and our faculty consultant is PJ Floyd. AHIMA says release of information in healthcare is critical to the quality of the continuity of care provided to the patient. It also plays an important role in billing, reporting, research, and other functions. In this presentation, we'll explore the assertion that EHRs have made ROI much easier in some ways and far more complicated in others. We'll talk about how these challenges affect healthcare system personnel and patients and their advocates. Talk about legal and potential litigation challenges for ROI, current and future e-discovery implications for health information management, relationship between goals for the management of health information and technology, and what programmatic recommendations our group suggests to meet these challenges. So the question is, have they made release of information easier? Electronic health records, that is. Release of information is a challenge. Healthcare organizations work under tight time frames as they work their way towards achieving meaningful use standards and get incentivized. Those that have not moved to a centralized ROI process, like electronic document management systems, often deal with unorganized, partial systems or silos of information to get the information they need, like going to different departments in a health organization. Routine audits are recommended to control this problem. That way the right information is released and the service is appropriately billed. And lack of trained staff can be a huge roadblock to smooth ROI process, and familiarity of federal laws, both state and federally, is crucial. When hospitals embrace EHRs, there are a lot of great benefits. They get computerized physician order entry, charge capture, preventative health, improved data accessibility, e-messaging between providers, and they can demonstrate meaningful use. However, these benefits do come with a cost. They have to be more vigilant on data security and data control and transparency. It can be expensive to implement, and providers struggle to meet standards of meaningful use. Implementation is ongoing, but adoption is out, interoperability is in. It's time for usability to take charge as health IT evolves and healthcare laws are fully realized. Providers, as they passionately show their resistance to the transition, are expected to be very prompt and cooperative to address clinical needs, track progress, etc. The risk of malpractice is both easily detected because EHR includes detailed information and not easily detected because computer data can be easily altered and manipulated. ONC and CMS are working to try to figure out how to minimize how much time clinicians spend on unneeded data entry, and the EHR vendors need to make their software more flexible. Advancing health information interoperability, transforming the regulatory system to keep pace with innovations in medicine, science, and technology, and improving care while lowering costs by harnessing technologies that have already improved other industries. In at least one case, CMS overpaid more than $729 million in incentive payments to eligible providers that didn't meet meaningful use requirements. According to a U.S. Department of Health and Human Services Office of Inspector General, CMS failed to conduct minimal documentation reviews, which officials said left the incentive program open to abuse and misuse of federal funds. There needs to be consumer access to help consumers easily and securely access their electronic health information. Direct it to any desired location, learn how their information can be shared and used, and be assured that this information will be effectively and safely used to benefit their health and that of their community. There should be no blocking, and transparency should be ensured to help providers share individuals' health information for care with other providers and their patients whenever permitted by law, and not block health information. that is, not knowingly and unreasonably interfere with information sharing. We should implement federally recognized national interoperability standards, policies, guidance, and practices for electronic health information and adopt best practices, including those related to privacy and security. So these changes do affect personnel, patients, and their advocates. Let's see how. Healthcare organizations change can affect not only the staff's behavior, but their job titles, tasks, and roles. While many physicians stick to the traditional way of doing their task, it is becoming more prevalent that physicians are taking the proper training and continuing their education so they can stay up to date with the technology and software, such as the EHRs. As for patients and their advocates, changes within a hospital can affect them also, especially regarding the release of information. While the release of information can be a hard process for some patients, we're working every day to make this process easier, but with so many individuals, organizations, etc. involved, it is important that the security aspect be taken very seriously, which requires continuous change and adaptation. Online healthcare is one change that has improved the access to health information, which in turn makes it easier for the hospital and its staff to give the patients the proper continuity of care across multiple providers. Changes in the healthcare system have also made healthcare flexible so an individual can still seek the proper treatment and not have the remote location, transportation, or schedule be a barrier to receiving care. Improved health outcomes and improved quality for providers and hospitals can be reached by public rating systems and effective tracking. So let's see some of the legal and compliance challenges regarding release of information. First, there are some human challenges, including improper disclosure, lack of trained staff with the inability to locate the policies and procedures if they exist at all, a failure to stay current with federal and state ROI rules and regulations, and an ability to comprehend core HIM knowledge and/or anatomy and physiology that would prevent them from responding appropriately to record requests. Best practice for quality control would be to conduct more routine audits. Information may be in silos and difficult to track. Best practice would be to hire a certified HIM professional or paralegal to handle ROI requests. Some of the greatest challenges of the information age arise from placing computer applications in healthcare settings while upholding traditional principles. One challenge involves balancing two competing values: free access to information and protecting of patients' privacy and confidentiality. Only computers can manage the vast amount of information generated during clinical encounters and other healthcare transactions. At least in principle, such information should be easily available to health professionals so that they can care for patients effectively. Yet making this information readily available creates opportunities for access by extraneous individuals. Access may be available to curious healthcare workers who do not need the information to fulfill job-related responsibilities, and even more worrisome to other people who might use the information to harm patients physically, emotionally, or financially. The HIPAA security rule requires implementation of security safeguards to protect EPHI. Types of security threats include human, natural, and environmental. They can also be internal or external. Intentional human threats, theft, intentional alteration and destruction, virus attacks, may be due to disgruntled employees, may be due to external hackers or pranksters, unintentional threats like employee error or unintentional alteration and or destruction, internal breaches, which are more common than external breaches. As telehealth and telemedicine programs continue to grow, there are concerns including the privacy during the transmission, video conferencing, transmission of still images, e-health, patient portals, remote patient monitoring, continuing medical education, nursing call centers. The security rule requirements covered entities to maintain reasonable and appropriate administrative, technical, and physical safeguards for protecting EPHI. South Carolina itself has some very specific legal mandates. In accordance with HIPAA regulations, psychotherapy notes are kept under strict security and require special authorization for release. Understanding precise and clear interpretation of South Carolina's laws regarding minors versus non-minors is challenging in regards to treatment versus making future decisions or plans for their own health care. South Carolina citizens aged 16 and older are considered an adult for treatment for health care. However, for advanced directive planning and psychiatric advanced directive planning, South Carolina law requires the citizen to be 18 years or older to be able to make advanced directive plans. New sciences and technologies always raise interesting and important ethical issues. Much the same is true for legal issues, although in the absence of precedent or legislation, any legal analysis will remain vague. Similarly, important challenges confront people who are trying to determine the appropriate rule for government in regulating healthcare software. The lack of clear public policy for such software underscores the importance of ethical insight and education as the exciting new tools of health informatics become more common. To have an electronic health record admissible, the court must be confident that the system from which the record was produced is accurate and trustworthy. To maintain a legally defensive health record, a health record's integrity, its accuracy, and completeness is critical. EHR systems also bring new liability and litigation risks, such as inappropriate use of the systems, privacy breaches, and inadvertent data disclosures, which in turn may impose heavy costs in terms of preservation of electronic information and potential litigation issues. Confidentiality, privacy, and security are essential components of AHIMA's goals in light of consumer and government concerns related to the development and use of EHRs and HIE, as well as the collection, storage, use, or reuse of healthcare information. Coming from a recent history of HIPAA privacy and security efforts and requirements, and now adding the impact of ARA high-tech legislation as well as state regulatory efforts, it is crucial that standards, certification requirements, regulations, and legislation be coordinated, unified, and administered to maximize the utility of health information while providing the desired protections to instill confidence in the technology and systems that will permit the goal for EHR adoption and use, as well as health information exchange. The population of educated and trained health information management professionals is declining as the need for skills in electronic health records and health information networks are exponentially demanding a larger cadre of HIM professionals. Qualified HIM professionals are essential to the planning, implementation, maintenance, and use of EHRs and HIEs in the sophisticated environment. Projected HIM workforce shortages must be examined, understood, and the critical occupation spotlighted. Now let's talk about current and future implications of e-discovery and health information management. Release of information is a critical aspect of any healthcare organization and is essentially a process by which health information is maintained and accessed by authorized individuals in a healthcare facility. According to the AHIMA ROI definition, is critical to the quality of the continuity of care provided to the patient and plays an important role in building, recording, research, and other functions. Some of the current challenges facing ROI and e-discovery in HIM: paper charts are still being used to provide the patient and to exchange with other caregivers as many healthcare facilities. Very few EHRs have interfaces that can be used to quickly and securely access medical record data, requiring the printed copy. While there are many federal government rules and regulations surrounding privacy and security of health information, currently there is no standard uniform state privacy law in use by all 50 states and the territories, and state laws also vary in focus, e.g. HIV or genetic information, as well as degree of strictness or protectiveness of patient privacy. Validating the accuracy of the data can be challenging. There should be a way to score the trust level of the source of data. Turnaround times on ROI needs to be adequately prioritized, emergencies versus non-emergencies, and should be as short as possible. Data from wearable sensors, EHRs, radiology and cardiology imaging systems, and genomic data are just some of the sources and types of data that will become part of the patient's electronic health information. The costs associated with maintaining and storing that data will increase as the need for more technology and staff who know how to use it are required. Privacy and security threats will continue to evolve, and systems will be constantly under threat of attack. Encryption and authorization methods will continue to get better, and HIM systems will have to be adaptable to these changes. Metadata is data inside the actual data, timestamps, locations, IP addresses, etc., will sometimes be more important to know than the actual health data, especially in litigation. Personal health record software solutions will soon be on everyone's smartphone or tablet. Health systems need to be prepared for this eventuality and should be able to interface with an individual's PHR. Maintaining quality control has and will always be fundamental to e-discovery in health. It's not how much data you can acquire, but how relevant and useful that data is to care providers. Verifying the identity and authorization of the requester of information will always be a challenge. Will ROIs require more than just a photo ID and signature? One idea is for the patient to be able to provide a phone number that the HIM system will dial, and then the patient can type in a secret code that authorizes the requester to get the information. What happens when one system says that the patient has an allergy and the other system doesn't? Is the information still considered valid, or can it be flagged as questionable? A good audit log should be in place to record all the steps in the process and timestamps for each step. This will provide the necessary insight into how long it takes to go through each step. That kind of information will be useful when trying to determine which step is taking too long and how to improve the turnaround time. Maintaining high levels of quality for ROI requires comprehensive facility-specific procedures that are documented, current and easily accessible to staff, access to appropriate state and federal regulation references, training programs for new staff members, education programs for current staff members, regular review of work performed to ensure standards are met, compilation of performance statistics. Now on to relationships between goals for the management of health information and technology. It wasn't until the 1920s that physicians realized the best practice to improve patient care was to carefully document observations and actions taken during treatment. In 1928, the American College of Surgeons standardized the growing number of medical records by creating the American Association of Record Librarians, which is known today as the American Health Information Management Association, or AHIMA. The 60s brought the mix of technology to the picture. The development of computers encouraged the idea to explore the marriage of computers and medical records. Downside was that computers were still too large and expensive, which meant only the largest organizations could use the technology to handle medical records. The organization that did opt for a computer system to handle medical records could only offer limited access to the records. The access was only available on the site that the record was created. In the 70s, computers were becoming smaller, and software was designed to support multiple different clinical functions, but these systems could only be department-specific and not accessible to other departments. In 1971, the first attempt at a total integrated health record system was implemented for the University Medical Center in Burlington, Vermont. In the 80s brought a need for more integrated, multiple disparate systems. This need arose from the advancement in personal computers and widespread health-related software applications. Even though technology kept advancing, most hospital departments could not access information outside of their own silos, which prevented data sharing. In the 2000s, the importance of integrated health records to enable providers to make better decisions grew, which led to hospitals implementing them to reduce medical error. The adoption of fully functional EHRs grew more significantly with the passage of the American Recovery and Reinvestment Act, the increased volume of data, ease of access to data, and the need for health information professionals to guide the management of health information. Currently, The management of health information and technology is a work in progress. The United States has a large installed database of systems whose functionality varies greatly. Patient data is typically spread over multiple sites instead of a single institution. Most of the current EHRs in use are provider-centric. This means that the EHRs are housed and maintained by the provider, and the data is owned by the provider. Today, healthcare organizations are implementing EHRs with a high intensity because of the American Recovery and Reinvestment Act. According to the U.S. Department of Health and Human Services, ARRA requires the adoption of electronic medical records by 70% of the primary care provider population. Out of the hospitals that have EHRs, only 41% of the providers are able to send and receive secure electronic messages containing patient health information to and from sources outside of the organization or hospital system. 41% is a low percentage compared to the amount of EHR usage and the need for exchange of patient information. Even though managing health information and technology has evolved tremendously, there are still a variety of issues that need to be corrected. One overall problem is that there tends to be inconsistencies in what is recorded and how the data is recorded. This creates silos of data that cannot be merged for analysis or patient care. These inconsistencies can lead to the disruption of the continuity of patient care. The unmerged data cannot easily follow a patient between facilities. Another overall problem is when there are duplicate and contradictory data elements in the health system. These elements, whether in the form of a double entry or contradictory disease indicators from separate departments, can create parallel and uncoordinated databases on the same population. The overall problems lead to the need to integrate and harmonize data to make it available to all users. Additional to the overall problems, managing health information and technology also has several ethical challenges to overcome. One being the privacy concerns in the case of releasing information to an unauthorized user. Ethically, the management of health information limits the access of the data to be able to preserve the privacy and confidentiality of patients. Another ethical management challenge is dealing with digital security breaches. Management of health information also includes the management of defense measures. Including defense measures like scanning for viruses and malware can ensure the protection of the privacy of the health information. Accuracy issues are another ethical challenge in managing health information. Inaccurate recorded information can lead to the possible harm of a patient. The information systems design functions need to be implemented properly to ensure that the user cannot skip data fields or any important information. The most important solution to the problems and challenges of managing health information and technology is making health information systems interoperable. The next slide goes into more detail about how this is the best solution. Besides interoperability, there are other options that can assist in solving the current problems. One solution that has worked in other countries is having a national unique patient identifier. The problem to this solution is that the Congress is currently prohibiting the use of federal funds to develop this. There are multiple drawbacks with using common identifiers to exchange patient records. On the clinical side, there is the issue of failing to retrieve needed records or obtaining the wrong ones. On the privacy side, there are issues with using name and social security numbers because of the vulnerability and connection to sensitive records. With having a unique patient ID, patients could control who accessed their information. Their medical information would have the ability to immediately be available when needed. They would not need to fill out the same information over and over again, and there would be no worry about mixing their information with other patients. Another solution is having core data sets. Core data sets are when the most critical data is defined for each application. This has the ability to cut out the unnecessary data collection that can bog down an information system. With the assistance from an interoperable system, core datasets can ensure that only essential data is captured from different agents in multiple settings in a comparable and consistent manner, which allows for analysis at a higher level without increasing the data collection burden on any system. Currently, EHRs are provider-centric instead of being patient-centric. This means that the providers maintain the EHR systems and most of them own their patients' data. Provider-centric also blocks the idea of interoperability by allowing vendors to have different versions. It also allows lab results, past documentation, and hospital visits to not be centralized, which can lead to ineffective and inefficient use of health information. By moving to a patient-centric EHR, patients are now in control of their own data. Any provider that treated the patient would input the data into the patient-centric EHR, thereby centralizing all the up-to-date data in one place that is available at all times. Patient-centric would also have the ability to cut down on the duplication of data, treatments, and tests on patients. Interoperability is the #1 goal to properly manage health information and technology. The Healthcare Information and Management Systems Society, HIMSS, developed a definition for interoperability. It is the ability of different information technology systems and software applications to communicate, exchange data, and use the information that has been exchanged. Having interoperable systems allows the sharing of data between the healthcare community no matter what application or vendor used. HIMSS also defines a 3-tiered model of interoperability that should be achieved. The first level is foundational interoperability. This layer lets the data be transmitted by one health information technology system to then be received by another. Not included in this tier is the requirement for the receiving system to interpret the data. This tier is the foundation of the pyramid, offering only the basic data exchange. That means this level is more on the technical side and not the focus for the clinical aspect. The ease of the exchange is the main goal, ensuring that technology is functioning correctly. The next tier is structural interoperability, which defines the format of the data exchange between the systems. The focus is on packaging the data by message format standards. For example, Health Level 7 provides guidance on how the message should be structured. This level is a mixture of both technical and clinical operations. On the technical side, the health data is transmitted through uniform movement from system to system. On the clinical side, the meaning of the data has to be preserved and unaltered. Semantic interoperability is the top of the pyramid. This tier ensures that the systems are able to both exchange and use the information that has been transmitted. The goal is that the transmitted structured message contains standardized coded data that can be received and interpreted. Semantic interoperability aims to bridge the clinical terminology between multiple systems and data sources. By having complete interoperable systems with each tier successfully included, almost each challenge to managing health information technology can be solved. Both managing health information and managing health technology should aim to have interoperable systems. That single goal shared between both can bridge the sides together and work towards improving patient care. Now let's talk about some specific programmatic recommendations to ROI challenges. In the past, mostly paper forms were used. You had to go in person and request the information by presenting a driver's license or a social security card, and there was no method for notifying you if somebody needed emergency access to your data. Currently, a lot of the time it's still paper. There is limited capacity for notifications. Sometimes you can get a phone call notifying you, but what happens if you don't pick up the phone? Also, custodianship is typically by the provider. It's not patient-centric at all. In fact, in at least 16 states in the US, it's actually a legal mandate that the provider retains custodianship of all patient data. In some health systems, they've started using blank check forms for rapid acquisition of information. So they ask you to sign a blank release of information form, stick it in your file, and then if there is an emergent situation, they can fill out what information they need and send it on with your signature. However, this is based on a common misconception since HIPAA doesn't require signatures from patients when the data is being requested for treatment or payment in most situations. In the future, there should be clarification from HIPAA and other laws about what is necessary and what they need from patients. As I said, signatures aren't usually required by HIPAA, though there is a common misconception that they are always required. There are apps being developed by numerous companies now that provide digital ID verification, where you can simply take a photograph of your driver's license and be verified remotely. And there should be more online portals to deliver notifications and allow people to filter through specific data packages that they can send on to a provider when they're requested. And for the distant future, to provide this layer of interoperability between all health systems, the blockchain, the technology behind Bitcoin, is an ideal solution. It's secure, it can be completely separate from all of the main healthcare systems, yet provide interoperability with all of them. It can maintain unique identifiers for patients and providers, and it can provide notifications to patients when something is changed or requested. And this gives the opportunity for custodianship both by the patient in a patient-centric way, as well as the provider, so that both the provider and the patient can decide what information is released and when and how. To summarize what our group recommends as solutions to some of the issues surrounding release of information: interoperability between systems. Blockchain can act as a relatively simple, though not necessarily easy, layer of interoperability and audit logging, while not forcing the major players in eHealth to interoperate directly with one another. The blockchain can also provide unique identifiers for patients without compromising Social Security or driver's license numbers, while still maintaining the patient's confidentiality. Furthermore, more training and awareness should be helpful with moving ROI into the 21st century, as can more effective incentive programs and adoption and adherence to data standards. Here are some references. Thank you very much. I hope this was informative. Goodbye.